you see a siren like in the US, any ambulance running a patient, an elderly patient to the hospital, it could be drug related. Not necessarily an overdose, but rather inadequate treatment too. And this costs money. So what's the message here? We are the makers of the drugs, but we kind of have stood back and just watching things happen. The message here, the take-home message as I kind of wind up, is that we should be in charge of the total drug use process, from the research and development Dr. Mann was addressing in the morning to the actual administration. In other words, all the entire process is like a manufacturing process. We are responsible for the QA. There's no way anybody takes over. A physician, a super consult comes in, but oftentimes these specialists prescribe from a limited formulary. An ophthalmologist, I can assure you, prescribe from only 20 drugs. He has no clue what the dentist is going to prescribe. He has no clue what the gynecologist is going to prescribe. And yet, the patient is going to take all those medications. It's only the pharmacist who has been properly trained who's responsible for the entire lot of medications. He's the one who has been trained on the body handles the drug, the pharmacokinetics, and the way the body responds, the pharmacodynamics. All those, and then the various dosage forms that are most convenient to the patient. So what am I saying? It's a high time we now move to make a pharmacist a provider. And this is where I'm about to end up. In other words, from our discussions, we should empower the pharmacists to make decisions that actually impact these pharmacotherapy outcomes. In other words, we should now be slowly transforming ourselves into drug medication use experts, not distributors, but use. It's a big thing. Even our training should be more on the medication use. We still have the responsibility of preparing the product, but the use, there's been a mess. In other words, one more saying that I learned from my professor in University of Minnesota was, there's nothing wrong with the drugs we use. They are very good drugs, but they're inappropriately used. So really, much of it, all these medication errors, there's about 1.5 million errors, medication errors in the USA that are actually preventable. So what am I saying? When you talk about the primary healthcare, meaning the most basic package of healthcare services that are targeted at the individual level, this is not public health, at the individual levels, were the first point of entry into the healthcare system. And for the pharmacists, for all those pharmacists who always think, oh, I'm not a doctor, you are a pharmacy doctor, and it's a parallel system. When a GP sees a patient, he's going to refer to a consultant, and the consultant is a subspecialist. So do not think you're just there, kwa Kiswahili kama mtu wa mkono. You are responsible in what you are giving out. The other definition of pharmaceutical care is the responsible provision of a drug product to improve the quality of life. In other words, what you're giving out, you should not be like a quack. You're actually responsibly giving out to ensure that that drug is both safe, effective, and that's the most affordable. So what am I saying? In primary healthcare, and that is why I end, pharmacists should be seen as healthcare providers, underlying healthcare providers. You should just sit there, and I do run a clinic. I don't stock any drug. I just stock the knowledge. And I've always thought I should be paid for the services. You see, the first comprehensive services that I provide is 10,000 shillings, and the follow-up is 5,000. You may wonder why the heck should it be 10,000. I'm saying this so that I can motivate you. In other words, you have to comprehensively look through all those medications, all the diseases, all the medications, to make sure the drug is indicated, it's safe, it's effective. It's effective, safe, and the patient able and willing to comply. So all I'm expecting from this conference, the webinar, I should hope that we should come up with an appropriate policy to change our training. Of course, I'm advocating for doctor of pharmacy training. And number two, to make sure that our practice is not in a Dukawala mode. There's a pharmacy care centers. We move away from the Dukawalas. Number three, proper job descriptions for pharmacists. And then we should also be having the primary care pharmacists who should be certified, and then also MTM should be an essential health benefit. With that, back to you, Chair, Dr. Mngoma. I will contribute later if there are any questions. Thank you very much for listening to me.
Thank you very much, Professor Ndemo, for that in-depth foundation on medication therapy and where we come in as professionals, as pharmacists. It's so important that you've reminded us, and this ties in with what was said earlier on by the chief guest, saying that we are probably doing 1/3 of what we are supposed to be doing. And we were reminded this morning that we need to look for other areas. We need to diversify. You know, there's so much we can do, and we need to take more ownership of these medications, because we are the people who are the custodians of this. We have been well trained, and we need to take charge. Self-care interventions for health are among the most promising and exciting new approaches contributing to universal health coverage, UHC. So the World Health Organization working definition of self-care says is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, cope with illness and disability with or without the support of a healthcare provider. So the scope of self-care in this definition includes health promotion, disease prevention and control, which again feeds into the definition of primary healthcare and what our theme is about. Providing care to dependent persons, seeking hospital or specialist care if necessary, and rehabilitation, including palliative care. Dr. Sylvia Opanga, are pharmacists in Kenya doing enough? One, to promote self-care, and two, to position themselves as consultants for self-care?
Thank you very much, Michael. I would first like to start by saying that pharmacy itself, community pharmacies particularly, are the first point of care. So patients within the community will go to a pharmacy first before they consult a doctor. They will always buy drugs over the counter before they consult a doctor. Now, when the patient comes to buy medication at the community pharmacy, what is it we are doing? Practice currently is that people just sell the medicines, but we need to do more. We are not doing enough, and as Prof has alluded, we are just doing 1/3 of what we should be doing. So what we should endeavor to do is to ensure that when the patient checks into the pharmacy, because if you're looking at primary healthcare, we're looking at the most basic healthcare provision. So the patient will come there before even they get a diagnosis. So what is our role as pharmacy? We have already established that we are not doing enough. Patients are coming to buy drugs over the counter. Some of them are even buying drugs online. Some of the online pharmacies, we don't know the credibility of them and what happens, but this is what should be happening moving forward. Once the patient comes in, spare some time to talk to that patient. Because you're a doctor, you have the knowledge. Most patients will come to buy drug X from prescribed by one consultant, those with non-communicable diseases and some other chronic infectious diseases like HIV will be having multiple medications. They will come for over-the-counter drugs. Some of them will interact with each other. Some of them will get very severe adverse reactions. I've actually seen patients developing very severe adverse reactions from over-the-counter medications, and they're admitted. So there's something that is missing within the community pharmacy level. What are we supposed to do then? Take some time to talk to the patient. Even when they're coming for just health supplements, some of this can also interact with drugs. Some of them are taking herbal medicines that are interacting with drugs or even making their diseases severe. So have a sit down with the patient. this will not be very effective over the counter. So pharmacies should go ahead and have consultation rooms where they can actually do medication reconciliation, look at what the patient is asking for, if they're on any chronic medication, review and evaluate, and make sure the medicines they are taking, they are safe and effective for their condition or multiple conditions. Then after that, develop a care plan with the patient. The one thing that has been missing in community pharmacy is that, number one, we don't know our patients. They come buy drugs and go away. Some of them may never come back. Some of them will come back as constant customers. We never document what we do in community pharmacy. So we need consultation rooms to be there. We need to be well equipped with the knowledge to handle patients, and we need to document what we do, and we need to follow up our patients. We need to know that if a patient is on drug X, are they developing a severe reaction? Is their medication effective? Is there anything else you can do as the pharmacist? Because medical doctors cannot do all this for us. They do what they're trained to do, diagnosis and prescribing. But then again, the ball comes into our court. What we've been doing is just dishing out medicines out of our prescriptions, and most of the prescriptions actually don't have the diagnosis, so you really don't know what you are prescribing drugs for. A lot of patients also come for over-the-counter prescription medicines, which is something that should not be happening. Any prescription medicine should never be sold over the counter. So those are some of the issues that we need to look into. Look for a structured way to evaluate our patients, identify medication-related problems, and resolve them, because that's our work. Our work is actually to diagnose medication-related issues, solve them, and develop a plan with the patient, then monitor the patient and make sure that they get the best outcome from their medication. The other thing that's very concerning for me is universal healthcare and how it has been rolled out. So we've actually been seeing non-professionals being handed over packages of drugs to go into the community and give to patients. That is very dangerous. Anywhere there is a medication, we always need a pharmacist to be there. And so we need to develop a strategy where pharmacists can reach out to patients in the community. I've been to developed countries, and we actually have pharmacists doing door-to-door visits for patients to review their medications, especially those who cannot make it to a healthcare facility. What can we do for our patients who are on multiple medications? What can we do for patients suffering from chronic illnesses? There's a lot of stuff that we can do as pharmacists, moving away from distribution and just dispensing, but actually providing real care, identifying medication-related problems, providing solutions for them so that patients can get the best outcome. The other thing I want to flag out is, how are we regulating the effectiveness of medicines which are being dispensed and prescribed online? Mostly, a lot of people will now go and just self-prescribe. They Google their symptoms, self-prescribe, and then they go to the online pharmacies to buy this medication. Is there a process that is clear so that when we're looking at primary healthcare, this is also something to consider because it's emerging, and we have to have ways of ensuring patient safety and the effectiveness of medication that is provided. So we have a very big role to play in primary healthcare. What are we doing at the lowest levels of healthcare? How are we handling patients within community pharmacies? And how are we looking at the issue of online pharmacies, and what can we do to ensure that our patients get the best from the medication? Over to you, Mike.
Thank you so much, Dr. Sylvia Panga. That brief conversation or explanation you've given there is quite packed. I think we really need to take time as people who are attending this conference, first to appreciate the caliber of people that are present with us, and really unpack what is being said here so that we look at ourselves as professionals, as pharmacists, and look at what we are doing and what we are not doing, because we need to be accountable. We need to be accountable for what we claim here, and also, our practice, and protect our practice. Dr. Kathari, have you joined us now? You had a little bit of a problem there. I just need you to say yes. Okay, so anyway, we'll get to him. But something just to mention here again, I think I'll go back to Professor Demo, that drug addiction is also something that we need to be addressing. And addiction here doesn't necessarily just touch on narcotics, but there's a report published online, and it says about 18 women die every day of a prescription painkiller overdose in the US. More than 6,600 deaths in 2010 were reported. Prescription painkiller overdoses are an under-recognized and a growing problem, especially for women. The report really focused on women. And it says that nearly 48,000 women died of prescription painkiller overdoses between 1999 and 2010. And some of these deaths from prescription painkiller overdoses among women have increased more than 400% since 1999 compared to 265% among men. It also says for every woman who dies of prescription killer overdose, 30 go to the emergency department for painkiller misuse or abuse. And if you look at primary healthcare, you look at pharmacies being one of the first points of care. Painkillers just being an OTC, or most of them being OTCs. And I must say that we also, we must recognize the fact that Pharmacy Employees has also tried to get in to try and stop the illegal sale of prescription medicine, more specifically codeine. But just to go back to these painkillers and their ability to cause harm, including death, what should pharmacists be doing, just to ensure that, as it has been described earlier, we're not dukawalas, or we are really encouraged to practice up to the level of selling or dispensing OTCs. Professor Nemo?
Yeah, okay, thank you, Dr. Mungoma. Actually, this is something that's very close to my heart. When it comes to the MTM, I didn't talk much about MTM. The fact that you are going to interrogate any prescription, be it over the counter or an actual prescription from a physician, if you're going to go through those 4 drug-related needs, you will find that, in fact, you will not go beyond the indication, whether the drug is appropriate. Somebody came for say, for example, for some over the counter, you have to establish if there's need. When you talk about indication, is the reason for taking the drug. If there is any medical reason to be taking the drug, at that point, either the drug is unnecessary or is being used for non-medical use, you can actually capture it at that point. So what am I saying? What has happened is that we're unable to do this because we just don't even document what we give out. Remember, OTCs are never documented. They are just sold like any paramende, like a grocery shop. So in other words, we have to slowly have a practice, what Dr. Opanga was referring to, we really need to, pharmacists must just get out of that counter and sit down and talk to patients. You do realize right now, and I'm kind of also addressing what you're saying. When you talk about addiction, that's the extreme end of the spectrum. Normally, there's a misuse, then there's abuse, then there's addiction. Others, the addiction is going to be psychological or actually physical. The physical one, they suffer from very severe withdrawal symptoms, and they just can't live alone if they are not on their medications. So what we are saying, we have done very little to control the use of this medication. So the answer is to be more, and also to have a national surveillance. In the US, I've even worked for large chain stores, I mean, as part-time. You have to, they had a register. You cannot go from one pharmacy to another. They go to the register and see whether you have actually picked the same drug from another pharmacy, because they keep changing. So that means the regulator must come in. But the pharmacist, being lazy, I'm very disappointed with pharmacists, including myself, we're doing nothing. Literally nothing. And all we have, I'm saying actually pharmacists, we potentially, there's a lot we can do. So, kind of responding to your questions, is the accountability. Do we keep records? If you kept records, you can quickly get data to show that this patient is actually abusing this drug. And again, when it comes to pain management, we don't have any center of excellence for pain management. What is pain? You know, it's a very complex subject as such. We don't have pain specialists in this country. When you have ulcers, you don't take Panadol for it. I'm just saying is that we really need to learn a little more. There's neuropathic pain. There are so many types of pains. So people should actually be trained. Some of them are innocent. They end up being addicted without knowing. So what I'm saying here is MTM, the medication therapy management, is key, because it will involve employing the pharmaceutical care philosophy of ensuring the drug is indicated that it's safe, effectively safe, and the patient is actually complying. And that is, then we'll have to be seen as diagnosticians. That's what Dr. Obama was saying. What we're diagnosing is drug-induced diseases or drug-related problems, not necessarily the primary. Remember, drugs cause injuries to bodies just like COVID does. So I don't know why. This is an area even in public health is completely avoided. There's no pharmacoepidemiology being done. So I'm just trying to tell you that the whole field, I've been practicing this for the last 20 years, it's a whole field that's just sitting there. So my answer to us, ourselves, is in the training, is in the practice, is in the way we compensate the pharmacists. If the pharmacists were to be compensated $1 million a month to actually look at, you have super pharmacists actually detecting all those problems. But we should move away from the mode of payment. Most of us are being paid based on the drug. We should be paid on medication management.
Thank you, Prof. Dr. Sylvia Pang, I know that you might be going away soon. I just want you to maybe make a comment on the concept of pharmacy care centers as a very good tool for pharmacovigilance, very quickly.
Thank you very much. So my perception of a pharmacy care center is more like a pharmacy clinic, a pharmacist-led clinic, where which then looks at issues of diagnosing again and resolving medication-related problems. Now, in that kind of setup, you have a private room to speak to your patient. When you're reviewing your patient, it is more like you have a sit down with your patient, and there's a structured process in which you review the patient to identify these drug-related problems. This review will include a detailed history taking and even physical examination of the patient. Now, when you're reviewing such a patient, what are you looking for? you're looking at the indication of the medication that the patient is taking. So is this drug that the patient is taking appropriate for the disease or disease conditions? That's what you're looking for. The second thing you're looking for now, when we bring in the aspect of pharmacovigilance, are you looking at, is this medication safe for this patient? Number one. Number two, is the patient experiencing any adverse drug reactions? Number three, is this medication of good quality to the patient? Now, those are things that you're looking out for from the pharmacovigilance angle. And then you're looking at, are there any organ issues, any drug-related diseases that you can pick up? Are there any organs damaged as a result of the patient taking the medication? Then the other thing you need to do is look out for effectiveness of therapy. So that's why I said you need to follow up your patients. They need to come back and report to you how they're faring on with your medication. If they can't come back, look for ways to call them, have Zoom meetings with them, follow up. Is the drug effective? Are their symptoms improving? Is there anything else you can do? And then look out for compliance issues. This is usually a problem, and socioeconomic factors here are important, including even the insurance they get. So my overall picture of a pharmacy care center is where patients come with different conditions, and you're able to sit down with them, do a thorough evaluation of the patient by speaking and even physical examination, come up with a list of medication-related problems, document them, come up with your solutions and the plan that you have for patients. Now, this can be done in the usual pharmacy setting, community pharmacy setting, where you can still sell your drugs, by the way. We are not saying that you move away from that. You can still do this, but you have your private room where you're consulting with these patients. You can also still just have a consultation room like Prof. Demo. I prefer to have a consultation room and sell drugs as well, because I'm still the pharmacist. So you can still do it both ways. And this is services that take time, because I have been running my clinic for 2 years now, and this is some place you can actually sit with one patient for more than 30 minutes, just going through their issues, and that explains why Professor Ndemo is charging so highly. But then again, these are services that you need to be compensated for, and if we rope in insurance, even better, because these are services that will improve the patient's quality of life and how they are responding to medication, and possibly reduce morbidity and mortality. I've done a couple of studies in KNH, and we've actually seen how patients are suffering from medication-related problems and the kind of morbidities they encounter just because of drugs. So this is a very huge area that we need to explore. Thank you. Back to Mike.
Thank you, Dr. Sylvia, for that. I think what I'm also picking up here is that we really need to have patient-centered pharmacy type of practice. I think that's something that's really coming out. And you've also pointed out the use of technology as we are moving into the reality of what the pandemic has exposed us to. You know, as pharmacists, as we were also told in the morning, we are quite, we're quite malleable. We change, we are adaptable. I think that's the word that was used. We are highly adaptable. And part of this adaptability with what is happening in the world now is that we need to update ourselves with technology as part of being very good in medication therapy management. Dr. Kathare, just unmute yourself because I need you to come in now. So we've talked about drug-related diseases or conditions or situations or events that come as a result of medication itself. It's supposed to treat, but it's causing problems. And I know that you're also very passionate with MTM. First, I just want you maybe to share with us your experiences in your MTM clinical practice in relation to drug-related diseases. Dr. Kathare?
Thank you, Dr. Mugoma. You can hear me?
Yes, we can. Go ahead. Welcome.
Yeah, thank you, Doc. I want to appreciate my panelists, Professor Demo and Dr. Panga. Actually, we thank God for this opportunity. And also, I want to celebrate PSK. You see, this is our 40th annual conference. And I think as a society, God has really helped us, and I think we are growing. Now, before I respond to that, Dr. Mugoma, is that our theme, this conference should always, actually should get into our mind very seriously as pharmacists and as professionals and practitioners. The issue is primary health care. Okay, it's primary health care and how a pharmacist can contribute to delivery of primary health care. And all of us, including our colleagues who are practicing, we need to embrace this and ask the first questions. Are we part of primary health care team? Okay, and if we are, then how should we enhance delivery of primary health care services as a pharmacist? And if we are not, what is the gap and where can we fit in? So I think our theme is very good. And now we bring in the issue of drugs under MTM. Of course, we have been doing MTM for long. This is, I think, 5th year. And we have like 2,200 patients for medication therapy management. But the most critical point is that medicines are very important. And I think every professional, including every government, medicines are very important, both to countries' economy and even to the health of the patient or the population. And these two issues, the importance of economy, the importance of medicine to the country's economy and to the health of the patient, they are very important, but they can bring a conflict of interest. And this conflict of interest is when the medicines are going to be used as economic income and again as interventions for patients who are sick. Now, this conflict, the only person or the only service that can safeguard between the country's interest of economic gain, especially in public hospital, private hospital, how much that drug generates. So if that is the economic interest in an institution, the other question will be, how many drugs should we put this patient on? The next question will be, if this patient is admitted, how many infusions should we put on this patient so that we can generate more money from this intervention? Now, the other side of conflict is the patient. Okay, how much is he going to spend on this medication? Now, who can now enter inside these two conflicts and bring harmony both to the state and to the patient? This is where now the pharmacist comes in. Because it's a primary healthcare delivery, the pharmacists come in and now try to justify. Is Dr. Mugoma supposed to be on 2 IV fluids? Is Dr. Mugoma supposed to be with 3 prescription drugs or 7 prescription drugs? Yes or no? On the other side, is the patient supposed to be taking 10 drugs? So this is the point where the primary service care by the pharmacist comes in and bring benefit to the state, to the institution, and to the patient. Now, the question that you are asking, Doc, is that we all agree as pharmacy drug experts that actually majority of conditions, they are not attributed to just microbial and other things, as Professor Demo used to say, but they are caused by drugs. Majority of drugs prescribed or taken over the counter can result to disease, they can be caused by the drugs. And majority of patients that we have been seeing out of experience on the ground is that you find out of 10 patients, 7 patients, out of 10 patients, 7 patients, the condition they have, the second condition, the third condition, and the fourth condition was as a result of medication. Either it was prescribed initially, and the patient changed to another prescriber in another institution, another prescriber put a patient on another drug. So you realize out of 10 patients, 7 of them, the third and the second and the third and the fourth condition was as a result of a prescription drug or a self-medication drug. So during MTM, we have found those patients, and now we have been able to cause the intervention. For instance, if you raise patient who has been diagnosed with hypertension and is put on the fasting drug, and this fasting drug, the patient uses for 6 months, the patient comes back again. He may not come back to KNH, if it was prescribed at KNH, he comes back to Gatondo. So once comes to Gatondo, he finds Dr. Kadari who is new to her, and then he put him on a second drug to manage pain, okay, which is as a result of the fasting drug. And the patient goes back to Meru, and he stays for another 7 months, and goes back again with another problem, and is put on another drug, which is a result of the problem of the second drug. So now you get that prescribing cascade is what now patient does not know whether it's as a result of drug. And now during MTM, you are able to educate this patient. This is what is started. For instance, we have several patients who have PUD, peptic ulcer disease, as a result of medication. We have many patients who have hypertrophy of the heart, the enlargement of the heart, as a result of hypertensive drug. We have patients who have got prostate hypertrophy, not because of the age, but because of the drugs. We have patients who have diabetes, drug-induced diabetes, and they didn't know whether it's because of the drug. So that's what MTM is doing to help this patient and also the prescriber. And Dr. Mugoma, see, I can talk. Dr. Mugoma, we need to understand that medication are most widely used interventions in healthcare. You understand? They are the most. And as we speak today, because in Africa we don't have statistics, in America, we according to the last drug report, World Drug Report, is called WDR, that is released by yearly. The WDR for 2019, it gave us a report that 5 million, they suffer from drug-related effects. We don't know 2020 and drug what it will be. So you can see that there is a cap. And as Professor Demo used to say, when we are talking about medication, they are the third cause of death globally. I think we need to worry, including the president, including every governor, everybody who is in the policy-making platform. We need to worry because we need intervention that can make this damned cause, the damned disease, which is causing death, that is medication errors, medication duplication, polypharmacy. How do we be able, how are we able to prevent this? So I think in the area of medication therapy management, it is the area that a pharmacist, as Prof is saying, that can cause intervention. There is no disease condition, there is no prescriber that is going to cause intervention by a medication. Now, who is doing follow-up on how this medication will work? Whether it's working, whether it's not working, what effect it will leave with this patient for the next 10 years? Because as Prof is saying, drugs are not food. If I'm taking contraceptive for 20 years, I must be ready to know what it will do to my body after 10 years. That should not be a secret. I should get a report. After 20 years, I'm going to have osteoporosis. I'm going to have osteoarthritis. That's a fact. So what should be done to prevent this patient to enter into that?
Thank you, Dr. Kathari, for that insight and the passion for MTM. I think also what is coming out, which I was about to ask you, but you clearly stated that medication-related morbidity, is yet to be recognized by government as a public health concern. I think this is something that needs to come out, that there are people suffering just because of medicines, medications. And in fact, in certain jurisdictions or certain places, there are proposals or there are certain people who are already doing this, where deaths attributable to medication errors are recorded on death certificates. That way you can also keep up with what are some of the reasons behind some of these morbidities and mortality. Because as you said clearly, Dr. Kathari, it's not about microorganisms only. It is also related to what people are accessing and consuming from some of these drugstores. There is something here maybe that Professor Demo, you need to come in as you provide certain recommendations. Gabriel, is alluding here, saying that is there a guideline on how consulting pharmacists at the community pharmacies should charge? And I think maybe part of this is that should we be developing, finalizing, or pushing an existing policy that should guide pharmacists to earn what they they should be earning, and not just providing professional service almost pro bono. Professor Ndemo?
Yeah, thank you, Dr. Montgomery. Again, as I told you, is my pet subject. What there is, you have to understand how a pharmacist is compensated. If you look at the Act, Cap 244, you are a custodian. You are actually a custodian of pharmaceuticals and poisons. You're not a practitioner. So in terms of compensating, no employer has ever thought that the pharmacy is there to safeguard the safe and effective use of medications. He actually knew the law requires that there be a pharmacy, and that's what they have done. And all these pharmacies, ever since even the farm techs were enrolled, so long as they're just to represent, they can have their wives and everybody else being there, but there's no service. So what I'm saying is that the model, the compensation model, has always been product related. Nobody's going to hire you, there are no medications. So what am I saying? In order to be compensated, number one, MTM, medication therapy management. That's all the group of services that ensure that the drug therapy is both safe and effective. The one Dr. Kadara is talking to. This has to be listed as an essential health benefit. When you get your package from NHIF, it includes dental services, medical services, medication therapy management services. There'll be cognitive services. Then they will have to they will give you an appropriate coding. In the US, it depends on the level of complexity. It's about, you'll be charging anywhere between $60 to $200 per encounter. That is for another day. So when we're saying, if somebody came in there and you decided you want to give them maybe Benylin, and then you charge them for the consultation, they will not see why, because they are paid for the product. They don't realize that information they were privileged. So what am I saying? Our move is to show our value to the insurers that in fact we both improve outcomes and save you money. That's what the MTM services have done. So we have yet to have that legislated, and then you'll be listed as providers. Right now, when they talk about healthcare delivery in this country, they will talk of doctors, meaning medical doctors. They don't think there are other doctors. Doctors and nurses and dentists and what have you. Pharmacies are never mentioned. Normally, then they will talk about drugs. So really, it may be a surprise to you. So to answer your question is, we cannot demand until this service, this component of medication use that the service you're providing, identifying drug-related problems, is compensated like any other practitioner. Is yet to be legislated and be recognized.
Thank you, Prof. Dr. Kathare, MTM. Do you feel, or what would be your view on inclusion of MTM in the curriculum, pharmacy curricula at the different levels? Do we have it, and how effective would it be if we really try to put a focus on that? Very briefly, I'll give you 3 minutes because we're out of time.
Okay, thank you, Doc. So I think Prof could be better because he's in a training institution.
Yes.
But and you yourself also. But maybe my opinion is it should have been done long time ago.
Your opinion counts. Your opinion counts, Dr. Kathare. So yeah, I just want your opinion before I give it back to Prof.
Yes, actually should have been done long time ago. because MTM is what position a pharmacist as a service provider. The rest of drug information, the pharmacists were informed. And actually the real role that the pharmacist should be doing is medication therapy management. And actually should be included in our curriculum such that when graduates are coming, they are able to do what Dr. Panga is saying. They can set themselves in a consultation room, they can do medication therapy review, they can bill. Actually what Prof was saying, currently the insurer, we cannot be reversed because of recognition and the policy issues. But what I say, Doc, is if we have 100 pharmacists who are doing pharmacotherapy, who are reviewing patients, then we are able to say this is the service we need to be reimbursed for. In MTM, what we do at our facility, we are what we call super pharmacy billing, because there are patients who are paying out of their pocket. There is a billing model, there is a billing structure, there is a disease and service coding, what Prof was talking about. So for now, we can be able to penetrate out of pocket market. We just bill it and patient pays. Then we try to incorporate into policy and then reimbursement from the insurance. So it shouldn't be incorporated. In all our pharmacies could. I think that should have been done long time ago, Dr. Mugabe.
Thank you, Kathari. Thank you, Dr. Kathari. Professor Ndemo, just your contribution and final remark.
Okay, actually, let me just clarify this. MTM is not taught at the university level. MTM is a service. It's a service like a medical service is not taught at the medical school. So we are confusing issues here. What is taught in the university level is pharmacotherapy or pharmaceutical care. So what am I saying? MTM is a methodology where you coordinate with other consultants and whatever and deliver. It's a service. That's what the patients see, that I went for MTM services. But the knowledge that you have is actually pharmaceutical care knowledge and pharmacotherapy, in other words. So what am I saying? The only way out is you cannot mix the old wine and the new wine, as they say. We'll have to destroy. Actually, mine is to destroy the BPharm curriculum completely. Why? That doesn't necessarily mean there are no elements. Because what has happened, I've been here for 20 years. Unfortunately, the scientists have been so hanging there and they're bombarded with so much content at the expense of the practice skills. So what we need is there is a model that we suggest already, even with the board. There will be a doctoral pharmacy whose philosophy from the word go is to produce a clinician. And it's not all that. Some can go to industry. They have what we call the concentrations. Those who want to go industry, there'll be a concentration. But primarily, the core curriculum will be patient-centered. But others who want to go to public health, there'll be like 4 or 5 tracks. So what am I saying? The whole philosophy has to be changed, and everything, what is going from the old curriculum can be included. If you don't do that, you'll be forever more talk about this. It should be from one go, just simply go to the doctoral pharmacy from day one. They'll be exposed to patients. They don't wait until the 5th year. So they come out, and then the experiential education, what they call advanced pharmacy practice experience, will be done the final year. They will sit for the board exams in the 6th year or the 7th year, depending, because it's a graduate program. They will be ready, and then they go for specialization. Then that type of preparedness will now put you at par with the medical consultant and others. But if we keep following this curriculum, we're getting nowhere. So my question to you is that the curriculum, right now, they are making a lot of amendments, even the BPharm, but truly we should just shift over and transition to the PharmD program. Not because I'm a PharmD, but because the philosophy is there, is already embedded. Go and just look at the curriculum and you compare with what we have. So that's my contribution. Back to you, Chair. Thank you.
Thank you, Prof. I think listening to all the panelists,
Dr. Mugabe,
Yes, is that
I
Dr.
just
Katare?
supplement something small what Prof have said. You see, what Prof is saying is true, but what we are saying, there is a structure of delivering MTM. It's not a specialization, as Prof is saying, but there's a structure, globally accepted structure of delivering MTM. Why this structure is important is for reimbursement purpose. What do you ask for reimbursement? What documentations that are needed to file maybe to Jubilee Insurance or any other Jubilee? So there are structure, what is going to be claimed, how much should CMR be paid from present medication review, what contact time that should have per section with the patient, maybe 45 minutes, what will be charged for PMR, personal medication record. So this structure of delivering MTM by a qualified pharmacy or specialist pharmacist is probably what used, such that when an MTM provided in America is based, we have the same structure that the MTM provided in Kenya pharmacies is building with the same structure. So I think that because majority of pharmacists may not know what kind of a structure do I need, what documentation do I need to file, what documentation patient take home or even to the insurance that patient belong to. So I think that is the kind of structure I'm talking about. Thank you.
Thank you, Dr. Katare. You're definitely a specialist in this area, and it's so important for all the participants and panelists, so everybody logged in here, to really appreciate what the profession is about and who we have here as very resourceful persons that can contribute towards what we are doing. And just to say again, we are clearly responding to emerging healthcare dynamics, which is the theme for this particular conference. I want to appreciate our panelists today, Professor Francis Ndemo, Dr. Sylvia Opanga, and Dr. Joseph Katare, for taking time today to come and talk to us about primary healthcare and how the pharmacist is plugged in. I also want to appreciate everyone who has put together this conference day one. I think we have had quite a bit of success. Dr. Evah Amwayi, especially just to set the ball rolling, Deputy President, as well as our chief guest. From me, Dr. Michael Mungoma, I want to say thank you and pass on the mic back to Dr. Evah.
Thank you so much for such an engaging session. I was very interested in everything everyone had to say, and it really shows that we are very invested in our profession, and we're also very invested in our patients, which should be the two things that lead us in life, actually, as pharmacists. I'll quickly ask to procure our 10 minutes so that we can be able to go through the questions on the Q&A tab, and maybe a few more. There's some questions that have been on the Q&A tab and the panelists have not answered, and they can come and answer. I will choose one question per panelist, and then I'll ask the panelists to please answer the question and type a response to each and every question from your end, right? So I'll start with the, I think Mr. Spencer was not in. So I'll ask from, I think, Dr. Simeon Onyango, how is the pharmacist placed in the management of information related to drug access at various levels of supply chain, especially in relation to decision empowerment? I think that is a comment, or yeah, or is it directed to Laura? Is it directed to Laura? Laura, are you on the call, Nabure?
Yes, I am on the call.
Yeah, so there's a little bit, there's some comments here. Yeah, as we talk about delivery of services of the pharmacist to the young pharmacist, how can we advise them on how to balance professionalism and lifestyle according to considering this is likely to tilt to survival? Okay, I'm sorry. I think you should answer the first question on supply chain. How is the pharmacist placed in the management of information related to drug access at various levels of supply chain, especially in relation to decision empowerment?
Okay,
You can take that.
All right, so from my perspective and InSupply's perspective, the use of data for decision making is key. And that's why we have some of the solutions that we have initiated in some select counties. The role of the pharmacist here would be like on the impact team slides that we showed, the role profiles, the different roles that are played there, one of whom is usually played by the pharmacist. If the county pharmacist then is the leader of the impact teams, the monthly impact teams or the quarterly impact teams, then they'll be able to get access and data for decision making and also for action planning that fit that scenario. And this is another reason, it's a very good question, and another reason I invite us to participate in our two data use solution abstract sessions that we have for some of the good work that our pharmacists are indeed doing around the country in the counties we work with.
Thank you. Thank you for that answer. For Dr. Mudune, I have a question here from Dr. Ogoya. Are the vaginal rings or LA implants prone to resistance as the oral PrEP formulations, or is their susceptibility lower as compared to the oral formulations?
Yes, thank you. I'm still here. So I think they are actually still prone to resistance. But remember, these are still the subjects of clinical trials, and they are not widely rolled out. And within the studies that are being implemented currently, still very controlled. So we've not reached to evaluation of resistance yet, because resistance really takes time to actually build up. So it is still a process that it's possible that they can develop resistance. But again, if you're using INSTIs, and INSTIs have been shown to be very, very effective, high barrier to resistance medication. And in cases maybe of the injectables, then I will think the possibility of resistance are low, but we cannot rule that out.
Okay, thank you very much. I think this next question might be, I think it was addressed during the panel discussion, but is there a guideline on how consulting pharmacists at the community pharmacist should charge? Maybe Dr. Mungoma, you can direct that question to the deserving panelists to answer. Is there a guideline on how consulting pharmacists at the community pharmacy should charge?
Thank you, Eva. I think we have already addressed that question, and part of what Professor Ndemu mentioned there is that we need to put value to the work that pharmacists are doing. So that kind of covers that question.
All right.
Maybe I can just add something.
Mm-hmm.
What has happened is the culture. You know, farms are very casual. The thing is, me, I've been working as a consultant. I was a drug registration consultant. Image is everything. When I told pharmacists, I was consulting in a regular hospital for 5 years, you have to show value. People don't just pay. They need to be knowing. When I provide MTM, the first thing I introduce what MTM is. I tell them, Mom, you've been seeing Dr. Onyango, yes. You've been seeing Dr. Y, yes. But now it's for me to clean up and make sure this drug is appropriate. So I'm filling in this gap on drug monitoring and follow-up and evaluation to make sure these drugs are working for you. If they don't understand, they don't know why they're paying. So if you want to do a consulting service, you really must set up not over the counter. When they see you among his other customers, they won't pay that 10,000. Why do? I pay here, the rent is almost 90,000. Why do I do? And I normally spend money on my suits. I don't just walk in there like that. So what I'm saying, the lawyers have kind of figured out this one. They give you a bill of 50,000, you don't question. So what I'm saying, whoever wrote that question should go and get a new wardrobe. And then number two, now I'm serious.
Well, this fashion sense of pharmacists is not all that good.
No, seriously. And generally, don't even handle the money. Let the secretary receive your money. Don't be there negotiating with the patient. I get me. So really, just tell them this is what I'm going to do. And when you're billing, you're clearly showing I did a comprehensive drug therapy review, and this is what I did. I coordinated with other consultants, and then you write a report. You say this is a report to take back to your primary physician. They'll pay. And I've done that. It's very painful. Sometimes it takes me like almost 3 hours if you want to do a good job. So what am I saying? At the moment, they can actually pay out of pocket. But for us to be reimbursed, insurances in the US, they demand you receive MTM. You don't go on looking for patients. They're sent to you. Are you getting me? So really, we have to fight for this model where they will come and see independently for MTM. That's my dream. I hope I addressed the question.
Yes, you did.
Can I add something?
Yes, please.
I think when what Prof is saying is true. When we are trying to set the question about compensation, the first thing should start from the provider. The provider as ourselves, we should be able to differentiate between a dispensing activity and an MTM activity. If we are able to distinguish between a dispensing activity or a function and an MTM function, then you realize MTM is a complex intervention. And then the issue of charges and all those things, then they can come in after that. Thank you.
Thank you. And then there's this comment, maybe our president can answer if he's still on the call, Dr. Machogu. As we talk about delivery of services of the pharmacist to the young pharmacist, how can we advise them on how to balance professionalism and lifestyle, considering they are likely to tilt to survival? I think this is something that happens a lot. We then think, okay, let's go and just get the money instead of being considering professionalism and lifestyle. If you're on the call, Dr. Machogu, would you care to comment?
Thank you. Thank you to the panel, Honorable Fellow, Dr. Ndemo, Professor Ndemo, Dr. Sylvia, and Dr. Kadari, my esteemed colleagues, and Dr. Ngoma for the moderation. First of all, we have the Psk Code of Conduct. It's on the Psk website. If I could have, I don't know if I'm able to share my screen now, but it's on the Psk website. If you go there, you'll be able to see the zero draft of what Professor Ndemo, I think Sylvia as well, and Kadare came up with to sort of give us a guide of, charges, even a guide of even how you present yourself, a guide on even a job description, so that you gain a level of confidence on what is it that you're meant to be doing. Because remember, some of these things, we have to start doing them even with the willing paying clients out here, yeah, before even as we work globally on getting the policy right, yeah. But coming to the question that you've just asked, Dr. Evah, I mean, the simple answer to that is just, belonging in the Psk, belonging to a Psk branch and belonging to the society, either a committee and plugging yourself in there. If we've seen in the past, we've been able to get young pharmacists, from when came to us unmarried, now they are married. We're not saying that we're the ones who hitched them, but getting that work-life balance. You're able to, when you work with other leaders, you're able to learn from our mistakes, learn from the vision that we have, as opposed to trying to make the same mistakes. So I'd say there are many of our senior colleagues and other esteemed colleagues who are available to mentor others. I think what you is the robustness of the young pharmacists coming in into the profession and willing to learn from others, and also willing to pay the time, because it's your investment will actually be time put in a year, 2 years, and you'll actually get that balance that you're looking for, or even some sort of laser focus in your career path, as opposed to just running around in the wilderness.
Evah, can I chip in?
Yes, sure.
Yeah, actually, having been at this game for many years, I'm almost 100 years old now. Now, my problem I'm having is we don't have enough role models. If you followed from the older professions like medicine, they kind of more or less practice what they preach. From the word go, they're taking their students to the ward rounds and what have you. They're there as registrars in their practices and what have you. All these ideals, okay, we're in a transition. Okay. Yeah, so we're in a transition. I'm sorry, I was interrupted. In the transition. So what do we need to do is to plant a seed. You can actually see Dr. Kadari is there, MTM. Obviously, the first ever mission was in Mombasa. MTM, and so all we're saying is that let's really truly have, we should almost ban lecturers who teach, who don't practice what they teach in the classroom. Me, I'm want to completely change in my school. We really need to have people who are offering service. You walk there and the students watch you, what you're doing, how you record, how you handle yourself. That is why we're lacking what we call teacher practitioners. We better be moving that direction. Not that it's not that we've been doing a bad job. That's the best we could do. So, but now we better have teacher practitioners, people who actually practice what we're saying. That's why I'm actually doing for the profession. The reason why I set up that clinic is so that you can do what I do, the records, what I do, the follow-ups, etc. So role models, yeah, we really need them. Please push, even for legislation from the board. We don't want clinical pharmacists who don't practice. They should be banned. Thank you.
Thank you so much for your comment. Yes, please.
I think what Prof have said, I like it. See, what we need to have colleagues is where students. See, we know ourselves, and we know we took on ground. We know how things are. I think the other time we talked about a respect of our professional, both from the higher candor to the lower candor to the higher candor. The other time I talked about a pharmacy referral system model. You see, what has helped other practitioners, like medical doctors, they have a very robust referral model that the patient will be referred from one center, from the lower candor to the higher candor to the mid candor. They have that system that respect one another, or maybe respect speciality. But when we look at a pharmacy profession, we don't have that. And you see, that kind of model is what makes a practice, is what grows a practice. Practice is not taught. Practice is developed and learned by mentors and by people who have a lot of experience in the same area. So if we can have a pharmacy consortium where we need to respect and understand and develop and structure and implement a referral model, all the way from technician, pharmacy technician, technologist, to a BPharm pharmacist, to a specialty pharmacist, to a consultant pharmacist. Before this patient ends up to a physician, or things that are related to drug, there should be that proper channel accompanied by a physician letter, a pharmacist letter, MTM letter to the next level. And this is what can make us grow the practice. And we will have several pharmacists working in a single place within different roles. Thank you.
Thank you so much for all your comments and answering the questions. I would just like to make the last remarks. I know I have procured 12 minutes of your time. Just one more minute to thank everyone who did participate in today's session. You have made it successful. right from the top to right now. Thank you everyone who has been able to participate into listening, asking the questions. I would just like to thank our sponsors, Bayer, Cosmos, GlaxoSmithKline, InSupply, and CAPI, and most of all our title sponsor, AstraZeneca, for sponsoring the conference. We acknowledge you and we thank you for the support you're showing to pharmacists. Please, I know there's some of you who've had a few problems into logging in. We are working and asking our platform supplier, Zoom, to be able to correct the situation. I know many of us have had trouble logging in and registering, but that's why we ask you to log in and register 1 hour before at 8 when we open the platform. So I'd like to close this session without much further ado, and please remember to register for your CPD points. The CPD video will play and you can leave. And see you tomorrow. Have a great evening, afternoon and evening, and yeah, let's talk tomorrow. All right. Thank you and bye-bye.